Welcome from CVI2017. I'm Dr. Michael Luna here with Dr. Nilesh Patel from the University of Miami in Florida. He'll be talking about an acute MI patient from a left main culprit lesion in a patient with core valve, aortic endograft, and severe PAD. Welcome.
Thank you for having me here. So I'm going to present this interesting case of 83-year-old gentleman who lives in Georgia and who was vacationing in the Key West. And one day in the morning started having chest pain and he was also having difficulty breathing and lying flat. So he decided to go to the nearest emergency room, and he was diagnosed to have non-ST elevation myocardial infarction and CLIP class 3. So patient was airlifted to our institute for urgent revascularization. This patient have a past medical history of extensive coronary artery disease with multiple stents, also have a AAA which was repaired with the EVAR in 2008, severe aortic stenosis treated with 31mm core valve at our institute in 2014, which was complicated with the vascular complication which required patch repair of right common femoral artery. This is the presenting EKG, which showed ischemic changes in the anterolateral leads. Within the 10 minutes of the arrival to CCU, urgent echocardiogram was performed, which showed that patient's ejection fraction dropped from normal to 30 to 35% with the new regional wall motion abnormality involving the mid and distal portion of the anterior wall and also anteroseptal wall. So we decided to take the patient to the cath lab. We initially had a very hard time engaging the left coronary artery. Using the standard Judkins catheter, we took non-selective pictures and we knew that we are dealing with the distal left main. Immediately, decision was made to intervene. We used 7 French EBU3 catheter through the right radial approach. We also had a difficulty time engaging the left coronary, so we used a stiff end of J-wire to get some support and without prolapsing this EBU3 catheter into the core wall strut, we engaged left coronary artery. As you can see, the patient have a severe distal left main, also extending to the proximal LAD. So a couple of points that I would like to mention here is before even doing the diagnostic cath on this patient with the core valve, you need to know the coronary height of the patients. Basically, the core valve implantation depth is recommended to 4 to 6 millimeter, and the skirt length for 31mm core valve is 12 millimeter. So our skirt is 4 to 6 millimeter inside into the LVOT below the annulus and 6 to 8 millimeter above the annulus. So for this patient have a coronary heights of 20 millimeter, so we had an ample room to engage the left coronary. But again, we have to make sure that we don't prolapse this EBU3 catheter into the core wall strut and we engage from above. This is another view, RAO caudal view. Again, you can see that this lesion is extending into the proximal LAD. So with with a couple of pictures and contrast, patient's blood pressure dropped. Now it's 90/60. Started become hypoxic, requiring 4 liters of oxygen. Not stable on the cath lab table. We immediately checked LVEDP was 33. So we knew that this patient now gonna need some hemodynamic support. As I mentioned earlier, that we cannot use the right common femoral artery because patient have a complication from the tower requiring vascular patch. So we access the left groin. Again, the obstacles are not done yet. Patient have severe peripheral arterial disease with EVAR structure in the abdomen aorta. We want to put the impella, but we didn't want to dislodge, or we didn't want to damage the EVAR structures. So we exchange 5 French sheet with the 14 French Cook Sheath. As you can see, my intervention fellow had a hard time advancing this 14 French Cook Sheath, but he was a very athletic guy, so he could easily advance, and the impella was placed appropriately. And we decided to go ahead with the provisional single stent approach. We put pro-water wire in the LAD and another wire in the circumflex to protect the circumflex from some embolization and abrupt closure. We pre-dilated the lesion with 2.5 by 12 and then 3 by 12 millimeter balloon. We put 3.5 by 12 millimeter drug-eluting stent, and which was post-dilated with the 3.5 by 8 millimeter non-compliant balloon. Everybody was happy with this final angiography result. Patient also started feeling better. Patient's blood pressure improved immediately after we put the impella, so we decided to remove the impella immediately after the PCI without disrupting or dislodging core wall or damaging the EVAR structure. Patient was transferred to CCU for further management. Post-procedure echo did not show any new aortic regurgitation, and the gradient across the valve was also within the normal limit. Patient was discharged home within the 3 days without any complication, and I just had a chance to follow up with him a year and a half back now. He enjoys his life, he still plays golf, and was very happy with the outcome that he had. So a few of the teaching points that I would like to make and I learned from this case is you need to know the coronary heights of this patient before intervening on the patient who have a prior core valve, as this is a supraannular bioprosthetic valve. You don't want to damage the skirt height. And the one thing that I was really surprised with as a first year general cardiology fellow is I was impressed that how you could possibly put a diagnostic or guide catheter through this small cells, but actually then I learned that this small cell can actually accommodate up to 10 French catheter. So as long as you don't damage the skirt, you can still intervene. And as we are proceeding with this tower in the intermediate and even the low risk patients, I think we need to have a real good idea about what kind of things we can even do after we put this core valve. And the third important point is impella position. We usually put the impella in a way that outlet is just outside the aortic valve, but with the core valve in position, we want to put it little bit higher. The outlet should be a little bit higher, so we have an outflow actually in the aorta, not interrupting the skirt of the core valve. So thank you so much, and happy to answer any questions.
Great. Yeah, that's a great case. I think the biggest learning, and I've had to do a couple of these interventions through core valves in the left main. As you mentioned, the engagement of this vessel can be quite challenging sometimes. What is your recommendation for the first catheter you should go for to do your diagnostic angiogram, and then take it from there?
So I have reviewed a couple of articles that was published, and they all recommended to go with your standard Judkins catheter. So try with that, and if you're not able to do with that, and then you can use the other catheter, but try to not use the catheter in which to engage the coronary you need to prolapse into this skirt. And if you don't have any choice, then as we did, use the stiff end of the J wire to get some extra support, so you engage the coronary from above and still you have some support.
Yeah, on one of the cases that I had to do a PCI on through the core valve, I actually had to use an XP30, so a smaller curved catheter, and that pointed through one of the stent struts and actually had to engage the vessel with a guide liner through that. So it's actually a good technique to consider when you're having trouble with these cases, to consider engaging with the guide liner itself. And sometimes you have to point the guide in the direction of the left main, put a wire from the guide and disengage, and then use the guide liner over the wire to engage and do it that way. It's a good tool to use in these cases.
That's an excellent point. And I think as we do more and more intervention, we're going to learn more and more about this thing.
Absolutely. Great case. Thank you so much.
Thank you so much.
All right.